Okay, what we're looking at here is the pectoral girdle. It's going to consist of the clavicle, the scapula, and the humerus. There are a number of articulations that we'll mention in just a minute as we do the bones individually. Can you hear me okay?
Yeah.
As we do the bones individually, and we'll discuss a couple of things related to the type of joint we're looking at as well, synovial joint. Am I moving? Is that cool?
Yeah, that's fine.
I don't know how wide angle it is. So, this is the scapula. Okay, and on the scapula, 6 different sides of it would be the inferior angle here. And then we've got lateral. This is superior, the top part of the bone. This is the medial border or vertebral border. This is the anterior surface here. And then the spine is posterior with the supraspinous, infraspinous area above and below it. So this would have to be my right scapula. Can you see it over there? Are you looking at this over there?
No.
This is the right scapula, sorry. This bone articulates with 2 other bones. Most superiorly, it's going to articulate, as we saw in the shoulder joint here, with the acromial end of the clavicle. It's also going to articulate laterally with the head of the humerus. Okay. There are 15 things that this bone has on it that we're supposed to learn in my class. Those things include the superior border, the superior angle, the suprascapular notch here, the vertebral or medial border and the inferior angle, as well as the subscapular fossa, the coracoid process, the acromion process or acromial process, the glenoid cavity. Above the glenoid cavity is the supraglenoid tubercle, infraglenoid tubercle below it. These are attachments of the triceps and biceps brachii muscle. On the back of the bone here, we're going to see the spine of the scapula, the supraspinous fossa above it, and the infraspinous fossa below, as well as the axillary border below the glenoid cavity here. And this is the inferior angle. Okay, as I said, this bone articulates laterally with the head of the humerus and superiorly and laterally with the clavicle, as seen right here. Okay, this is the humerus. This is the top or proximal portion of the bone. This is distal. This is medial. The head is medial, and so is the medial epicondyle. Opposite the head will be the deltoid tuberosity, so that is lateral here. This is posterior, the deeper of the 2 fossa. This is the olecranon fossa. It's posterior and distal. And the coronoid fossa is anterior with the trochlea and capitulum. So this is the top or proximal, this is distal, this is medial, this is lateral, this is anterior, and this is posterior, and therefore this is the left humerus. This bone articulates proximally with the glenoid cavity that we just looked at on the scapula. It also articulates distally with the trochlear notch on the ulna, and when you flex the forearm or antebrachial region, it'll articulate as well with the head of the radius as the capitulum and radius come in contact with one another. The bone has 19 different things on it that you should focus on. Those things would include the anatomical neck, the surgical neck, the head of the humerus, the glenoid cavity, which would articulate with the glenoid cavity. This is the greater tubercle, the intertubercular groove, and the lesser tubercle are all opposite the head on the lateral side. Spiraling down from that point, directly down below it, is the radial groove that's going to spiral around laterally and meet with the capitulum below. It's also got the, as you move down, the deltoid tuberosity that I mentioned before, lateral, opposite the head, with that radial groove. As we move down distally, we're going to see the supracondylar ridges, the medial and lateral epicondyles, the trochlea, which is right next to the medial epicondyle, and the coronoid fossa, the more shallow of the 2 fossa, and then the capitulum is lateral. On the side of the capitulum, as you flex the forearm or antebrachial region, the head of the radius will come up into a much more shallow fossa on the anterior portion called the radial fossa. On the opposite side, the posterior side, we see the deep olecranon fossa for the elbow or the ulna, and that's going to articulate here with the trochlea below it, distal to it.
There you go.
I haven't even looked at these lists, so there we go. Well, I have. I made them. All right. The radius and ulna are the forearm or antebrachial bones. Joining the two, and between them, we would have an interosseous membrane that exists right here between the two, and that's a certain type of joint we'll discuss later. The two styloid processes are going to be distal most on these two bones. You can see, we'll do the ulna first, but as you place these two bones, they will go directly with the pinky and radius, or sorry, pinky and the thumb. The pinky bone would be with the ulna, and the radius is lateral with the thumb. As you place this bone, it needs to be placed correctly. It can go on either pinky, but the medial aspect of your arm in the anatomical position will show that this structure, the groove or the radial notch right here that's proximal and lateral on the ulna, must be placed on this side, making this the left ulna. Right above it is the trochlear notch. The trochlear notch consists of two structures: the coronoid, the lower or distal most coronoid process with an N. There's also a coronoid process in the mandible, so if you confuse those two and you're looking at the mandible, you'll probably get that right still. The top structure of this bone, making up the rest of the trochlear notch or semilunar notch you see here, is the olecranon process. This goes in, articulates proximally on this bone with the olecranon fossa and coronoid fossas, respectively, on the humerus that we just showed. This, as we said, is the pinky medial bone in the anatomical position, and therefore this radial notch proximal on this bone shows that this must be the left side. This bone has, in addition to those structures, the interosseous portion of the bone, this pointed portion that's going to link and bring blood supply and nervous supply to both of these bones at once. It also has a styloid process that would be the medial-most structure, and this bone articulates distally, not only with the radius lateral to it, but it also articulates with the lunae in the carpal bones. Again, this is the left ulna. As these two bones go together, you have an articulation point distally and proximally. The head will be the proximal articulation on the radius in the radial notch we just described, and the anterior-most radial tuberosity is going to be pointing slightly medial and linking with that interosseous membrane below. Distally, you have the ulnar notch that's going to be opposite the styloid process of the radius. The styloid process of the radius is what we'll use, in addition to either the concave curvature that you see here, distal on the radius, or the anterior medial proximal structure, the radial tuberosity. This is a common dislocation for small children. The parents will grab their hands and twist them in a circle, often dislocating these two bones, and the annular ligament that surrounds the head basically slips off of the head of the radius, and it's a fairly common injury that would be corrected rather easily, but prevented also rather easily with a little bit of knowledge. This bone, the radius, is also going to be the left side, since we see the concave curvature. This structure is anterior, and the styloid process is lateral most, closest to the base of the thumb on this left arm. So this is the left radius, and the distal articulation with this bone would be the scaphoid bone in the wrist. Is that all? That's it.
Get it?
Are we good?
You're on.
Okay, this...
Oh, if one thing, when you are showing it, if you could always like make it like as curved as possible, just because when it's like this, it's just, I'm not seeing the actual depth of it.
To point to.
Yeah, that's
Is that cool?
Yeah, that's good.
Okay.
Yep.
So, understanding that this is the This is the left hand in the anatomical position. So a couple of things to pay attention to as you look at this left hand. First would be the way that you designate that you're looking at the anterior aspect or the palmar surface of the hand would be the presence of the pisiform and the hamus or hamate bone, the hook that's seen here that articulates with the fifth metacarpal in the hand. As you number the hand bones, it's going to be numbered from thumb to pinky, and that would be from lateral to medial. So this is 1, pointer finger is 2, middle finger is 3, ring finger is 4, and pinky is 5. As we look at the different bones that are present here, the easiest bones to learn would be those that are distal most, and that would be because as long as you get the numbering down from 1 to 5, each of the fingers are going, or digits are going to have, with making up the phalange, 3 component parts: the proximal, the middle, and the distal phalanx. Those 3 collectively or combined are going to be referred to as digits or the phalanges. So this bone here would be the 4th distal phalanx, 4th middle phalanx, and 4th proximal phalanx here. All right, so in addition to those bones that are just the same in the other hand, just arranged oppositely, we're going to have metacarpals and carpals. The carpal bones are the 8 wrist bones that we mentioned a moment ago that are articulating with the antebrachial bones, the radius and ulna, and the scaphoid and lunate are the 2 bones that we'll mention in a moment that go with that. The bones that I'm mentioning here that are distal, that are long bones here present attaching to the 4 distal most carpal bones would be the metacarpals 1, 2, 3, 4, and 5. Proximal to these bones, the 4th and 5th metacarpals, you're going to see the hamate bone that I mentioned a moment ago that indicates this is the anterior surface. If you look at the posterior surface, everything is flat, and it's very easy to, if you're not aware of that, confuse this hand with the right hand in the anatomical position if you're not looking for the pisiform fused to the triquetrum and the hamate bone. So the metacarpals then proximally are going to articulate with 4 bones. As I mentioned, the 4th and 5th metacarpals articulate with the hamate. The 3rd metacarpal articulates proximally with the capitate. And the 1st and 2nd metacarpals articulate respectively, the 2nd with the trapezoid and the 1st with the trapezium. Proximal to that, you have another row of 4, and those would include the scaphoid, which articulates thumb side with the styloid of the radius and the distal portion of the radius, and the lunate here, which articulates proximally with the styloid and the distal surface of the ulna. And then the triquetrum is the square bone that's seen here with the circular fused pisiform on its anterior surface. You good?
Yep, we're good.
Okay, this bone by itself individually is referred to as the os coxa, or the hip bone or pelvic bone. It's rather easy to determine right or left on this bone because, as seen here in these pelvic girdles, on this model we have the pubic symphysis, the pubic portion of this bone that's going to be anterior most. And then lateral on this bone, the head of the femur, the longest bone of your body in the upper leg, is going to articulate with the acetabulum. We'll look at those in just a minute to determine right versus left and male versus female for the pelvic girdle. So indicating the 6 different sides of this bone, we're going to see that on this bone there is an arrangement of 3 different portions to it, and those 3 portions form a Y in the acetabular fossa right here. That Y would indicate here that the top portion is one part of the bone, that's the ilium. The posterior portion that's here is the ischium, and the anterior portion, as I just indicated, is the pubis, or pubic bone, forming here pubic symphysis and joining together anteriorly the os coxa. Posteriorly, we would have the sacrum bringing it together as well, forming the entire pelvic girdle. As we follow this line directly down, it's going to move through this opening, the obturator foramen, and then join again at the base on the ramus of the ischiopubic portion of this bone. The different sides of this bone then are relatively easy to determine. This is anterior, it's the pubis. This is lateral and facing anterior as well, that's the acetabulum. And therefore, if this is lateral and this is anterior, this is medial, this is posterior, this is the top where my thumb is, here's the bottom, and this is the left side, os coxa. On this bone, there's 18 different things that are needed that you guys need to master. We'll start at the top. This is the iliac crest. There's also a gluteal tuberosity backside on it. I don't know if that one I don't think that one is mentioned, but anteriorly on the pubic side, you have the anterior superior iliac spine. Below that, the anterior inferior iliac spine. Posterior, you have the posterior superior iliac spine and the posterior inferior iliac spine. And directly below these posterior structures, the greater sciatic notch, ischial spine, and lesser sciatic notch. On this side, we move back to this portion. This is the superior ramus of the pubic bone. This is the point where fibrocartilage would connect this os coxa anteriorly to the other side, to the right side os coxa. And then lateral, we have here the acetabulum that's going to have a fossa deep and sort of inferior within it. Below that, an acetabular notch. Then this is where nerves pass through the obturator foramen that I mentioned a moment ago. Down below this ischial spine that was posterior, we have the ischial tuberosity. The curvature here is the ischial ramus. This is the ischiopubic ramus down below, this joining point in the Y. And then we have the inferior ramus on both sides of both the ischium and pubic portion. And this is the superior ramus of the pubic bone. This is a bone that's going to be used readily for determining right side or determining male from female. There are three basic characteristics. 90 degrees would be the female larger foramen laying down of the iliac crest, and then a more upright iliac crest, smaller foramen, and a 60-degree angle would be the male pelvic girdle. Okay, so where we go, ready?
Yep, we go.
Okay, as we just said, the clavicle is going to articulate laterally here, the flattened end, the acromial end, where you see this this curvature here. Since this is the right side pectoral girdle, we're going to see a concave lateral curvature, convex medial, and then this bone will sit on the manubrium of the sternum. Also, this is the sternal end. The flat portion of the bone is the acromial end, lateral portion. So there are a couple of things that you would use on this bone. The main thing to be used is those curvatures I just mentioned, concave laterally with the flattened acromial end, convex medially with the sternal end that sits on the manubrium of the sternum, and then the very important conoid tubercle seen here that will be pointing on the lateral side, posterior and inferior. If this bone were placed upside down so that the inferior portion were upright, it would appear as the opposite side bone, as long as it wasn't determined that this is the conoid tubercle that should be pointing actually down. So this in fact is the left clavicle, and the conoid tubercle here is going to be on the lateral side pointing posterior and inferior.
We're good.
Good? You can see all of it?
Mm-hmm.
Okay, so this is the femur. The 6 different sides of the femur, much like the ball and socket joint in the pectoral girdle. In the pelvic girdle, we're going to see that this ball right here, the head of the humerus, or head of the femur, is going to be articulating with the acetabulum that we mentioned a moment ago, that had the 3 bones coming together, or acetabulum. The acetabulum is the lateral articulation on the os coxa, and therefore this head will always comprise the medial proximal portion of this bone. The trochanters would be lateral most, also proximal, and then we have distally the condyles, the 2 condyles that we're seeing here and here, meet the lateral and medial condyles, and then anteriorly we can see this smooth patellar surface for the sesamoid bone that is the patella. The patella is hard to pick up, and sits, like we see here, embedded in the patellar tendon on that surface, gliding smoothly across its surface. So this is distal, this is anterior. The deep notch that you see here in between the two condyles is the intercondylar notch, and that's a distinguishing characteristic that is posterior and distal on this bone. Directly above it, if you place a line above the condyles here, trace the bone up along the supracondylar ridges to the linea aspera, we see this popliteal space that's often asked about, a very vulnerable area to injury on the back of the knee, since there are no protective structures above it. Arteries and nerves pass directly along that surface. If we go back up proximal then, to recap, this is proximal. The head is medial, trochanter is lateral. This is the anterior surface, as we can see with the patella, that's distal. Patellar surface is distal. And the posterior surface is the intercondylar notch. And therefore, if this is posterior, this is medial, this is proximal and distal, this is the left side femur that articulates with the acetabulum of the left os coxa. On this bone, there are also nearly 18 things that need to be, I think 18 things that need to be addressed. Of course, on this bone, just like the long bone that we saw a moment ago, it's the humerus, we have an anatomical neck here that's just lateral to the head. We have the head. In the head, we have this fovea capitis that attaches in the acetabulum and maintains and stabilizes this ball and socket joint using a structure called the ligamentum teres that attaches it directly into that socket. This pelvic girdle is going to be stabilized by a number of ligaments around the top and bottom, and the bottom portion of this bone, as it is in the pelvic girdle, is going to be stabilized by cruciate and collateral ligaments, and the meniscus of the knee will be present for weight-bearing purposes. We'll mention that in a moment. So at the anatomical neck and surgical necks, just like on the other long bone, we have the head that's medial. Opposite the head, in the humerus, we had smaller structures that were tubercles. These are the largest type of process where muscle attaches, and these are therefore trochanters. So the structures we're seeing here, this is the greater trochanter, here's the lesser trochanter. Anteriorly on this bone we see the intertrochanteric line, and posteriorly the intertrochanteric crest joins them. Right at the base of this structure and lateral to it, you find the gluteal tuberosity. And as you move down the leg on the posterior side, you will see the linea aspera, as I said, that terminates into this triangular area, the popliteal space. And then if you move down to the medial and lateral condyles of the femur, they would have, of course, posteriorly the intercondylar notch between them. On this bone, just like we saw in the other bone, there's going to be, since there are condyles, there is a supracondylar ridge up highest, closest to the diaphysis of this bone. It would comprise the metaphysis that we'll mention in just a minute, and it would be the location for growth plates, epiphyseal plates, for secondary longitudinal endochondral ossification. Just above, if you look down below the medial side here, just above the medial condyle, you have the medial epicondyle, and on that structure you're going to have the adductor tubercle that sits right above it. I think that's everything, right?
Yep.
Okay, the lower leg bones, relatively easy. There's not a whole lot to learn on these bones. It's just a matter of orientation. They're going to, let's do the tibia first, the medial bone on the lower leg. Again, in between these two, you'd have, just like we saw in the forearm or antebrachial region, an interosseous membrane that links these two bones and provides nerve innervation and blood supply to both of these long bones as they develop. The structure of the bone that we have right here is the tibia, and to determine right from left, you place it distally, the medial malleolus here, and the articular surface for the talus in the foot. This protrusion or bony process right here is the tibial tuberosity. This is the attachment site for the sesamoid bone, or that is the patellar tendon, or the sesamoid bone is the patella, and its attachment distally is going to be right here along the front surface of the tibia at the tibial tuberosity. Directly above that tibial tuberosity, that is anterior and proximal on this bone, you see the most proximal surface here and the two sort of crowns or horns that are sitting between where the condyles of the femur would sit. These are called condylar facets. Sitting on both of them, you'd have a fibrocartilaginous meniscus that's providing resistance to tensile displacement of this joint, and it's also going to, since the femur is weight-bearing, this bone would be as well, the tibia, and that's why this bone is so thick sitting beneath the femur. The tibia, this tibia, so this is proximal up here with the intercondylar eminences. These eminences are going to be where we attach ligaments. We'll talk about that in a minute. But if these are proximal, this is anterior. This medial malleolus is most medial on this medial bone, then this has to be the left tibia. There are 4 articulations with this bone. It's often confused as having 5, but the patella itself is only articulating with the femur. It just attaches its muscle that the bone is embedded in. It attaches at this point on the bone. There's no real surface-to-surface contact or articulation site between the patella and this tibia. This is the shin, the anteriormost structure right here. This is the medial malleolus. As I said, these are often referred to as supracondylar facets, but they're also referred to as the medial and lateral condyles of the tibia. On the lateral condyle of the tibia, where the other stabilizer of the lower leg and ankle is located, this is the fibula. The fibula has an articulation proximally and lateral on this bone, and the condyles of the femur would also articulate proximally on this bone. Distally, you have an articulation with the lateral malleolus and the fibula. Opposite the medial malleolus, and then the talus of the foot would be what this bone sits down on top of and is stabilizing the ankle joint with. So this is, again, the left tibia. It would articulate with this left fibula, not the fibia, the fibula. And this bone is going to have 3 things that are used to determine its 6 sides. The most prevalent would be that the pointed bone, portion of the bone down distally here, the pointed arrow sort of structure that is the lateral malleolus is always distal. The hooked shaped structure that you see here and the more densely packed and thicker portion of the bone is always proximal, articulating laterally on the condyle of the tibia. So on those surfaces, both of them, you can see a smooth articular surface where articular cartilage would remain and sit in between the tibia and this other bone. And notice that this bone that I'm holding here laterally is not going to show or provide any weight bearing or resistance to a center of gravity. It is only stabilizing the lower leg and ankle joint, respectively. The way to tell also that this bone, other than the proximal, distal, and medial surfaces right here that articulate, would be that down on the lateral malleolus, on the posterior portion of that actual bone, you're going to have a straight line of no curvature, straight line directly down into that lateral articulation on the tibia, and then the rounded portion seen here of the lateral malleolus is always facing anterior and distal on this bone. So this has to be with this other bone. Both of these would be the left side, lower leg. Notice the rounded structure in the lateral malleolus and straight up and down posteriorly. Feel your leg, trust me, it'll work. This is also going to articulate distally with the, not only with the tibia, but the fibula will articulate laterally on the talus as well, stabilizing the ankle and lower leg with the foot. I don't drink it.
Yeah.
Right, we ready?
Yep.
Okay, this is the right foot. As we saw in the hand a moment ago, there are a number of analogous structures that we see on them. They're going to have the same basic makeup. The thumb, the one major difference is that the thumb in the anatomical position is always a lateral structure or lateral digit, and here the big toe, the equivalent of that thumb. The big toe will be medial most on the leg. It's not going to be turned upside down. This is the base of the foot. Here's the top surface of the foot, and therefore instead of carpals we will see 7 tarsals here in the ankle. Then we'll have metatarsals rather than metacarpals, and the same arrangement of phalanges or digits that we're seeing here. It's just the numbering will be opposite. So medial on this bone, we have the first digit here, or the first phalange, and metatarsal. This is the big toe. The second toe here would have, like we saw in all the other fingers or digits in the hand, from the second to the 5th toes we're going to see a proximal, middle, and distal phalanx comprising the digit or the phalange itself. On the big toe and thumb, remember we only had a proximal and distal portion. Proximal to those phalangeal bones, or the phalanx that is proximal, we're going to see an articulation with the 1st, 2nd, 3rd, 4th, and 5th metatarsal. Like we saw in the hand, we saw 2 bones that were articulating most most medial with the pinky and the ring finger. Here we see the pinky toe here, the 5th metatarsal, the 4th metatarsal, both articulating with one single bone, just like we saw in the hand with that hammus. This would be called the cuboid bone. We'll discuss that in a minute. So if you look at the hands and feet, just the phalanges alone and each phalanx make up a total of 56 total bones. The numbering is the only thing that's difficult to remember, or that needs to be remembered in order to identify them individually. The 1 is medial in the foot. The first finger is lateral in the hand in the anatomical position, the one major difference. Luckily, the 3rd one in the middle is always the same. Here's therefore 56 total bones, hands and feet. Here are metatarsals, that's 10 more. And then metacarpals, another 10, that gives us 76 just in the long bone portion of this structure and the hand as well. Okay? Proximal to these metatarsals, as I said, there's going to be, instead of 8 carpal bones like we saw in the hand with the metacarpals, here we have the tarsal bones. There are 7 of them total. The talus that I've just mentioned is the proximal articulation with the lower leg bones, both of them. This is the talus. The heel bone here is the calcaneus. As I move, we'll move clockwise here. So this is the calcaneus, this is the talus. Anterior to the talus we have the navicular, and more anterior, as you move distally on the foot, you're going to see the navicular will articulate distally with the 1st, 2nd, and 3rd cuneiform, or also referred to as the medial, intermediate, and lateral cuneiform bones. And most lateral here with the pinky toe would be the cuboid. It's also articulating, the cuboid is the bone that articulates both with the 4th and 5th metatarsal respectively in the foot. So to recap, this is the right foot. This is the big toe, number 1, 2, 3, 4, 5. Here we have the calcaneus, talus, navicular, 1st, 2nd, 3rd cuneiform, and cuboid tarsal bones, all articulating with each other and distally with the metatarsals.
We're good.
We good?
Yeah.
Nick, are we good?
We're good, Dr.
All right.
Patrick.
That's affirmative. All right, there are 4 main sutures of the skull that join the flat bones that develop through intramembranous ossification beginning at 2 months in to embryonic development. They include the occipital bone joining to these 2 parietals via the lambdoidal, L-A-M-B-D, lambdoidal suture. The occipital, the crest here, you have a protuberance right here on the back of your head. That's the external occipital protuberance, attachment of the trapezius muscle here. So if you go directly up from that, you have the crest of the lambdoidal suture. And on this suture, you're going to find specialized bones, or sutural bones, referred to as Wormian bones. So look for those. Each of the individual bones on this lambdoidal suture are referred to as sutural or lambdoidal bones. At the crest of that lambdoidal suture, you have 2 parietals coming together along this suture, and that is the sagittal suture, which basically terminates in the coronal suture that joins the parietals to the frontal bone. So this is the sagittal suture. The coronal suture joins these two parietal bones to the frontal bone. And on the side, where the greater wing of the sphenoid passes below the arch in the cheek, you have the squamous suture joining the temporal and the parietal bones and temporal to the sphenoid. If you look up underneath here, the mandible will be learned separately, but in the orbit of the eye there are 7 different bones. Medially, from anterior to posterior, you're going to be able to see here the lacrimal. This is where your tears surface. Even though the lacrimal gland is on the eye laterally, there's a duct that connects and the tears come out medial on the fleshy part, the medial canthus in the corner of the eye. So this is lacrimal. This right down below is the maxilla. Here's the zygomatic bone. And the way that I remember these bones, by the way, is Fezlamps, F-E-Z-L-M-P-S. So the letters of that mnemonic are going to go together with the specific bones of the orbit of the eye. The orbit of the eye is going to stop medially at the nasal bone here. The maxilla is going to join to that. So maxilla, once again, lacrimal. Then if you look lateral, here's the zygomatic. The roof of the orbit is the frontal bone. Okay, and then if you go back on this medial wall of the orbit of the eye, behind lacrimal, you will find ethmoid mostly, and then you have a small piece of palatine, and then back behind that with the superior orbital fissure, the hole in the far back, we would have the greater wing of the sphenoid bone. And the last one that we would have here would of course be the zygomatic again. So we'd have, one more time, maxilla, lacrimal, ethmoid, palatine, sphenoid in the very back, and zygomatic lateral, F-E-Z-L-M-P-S. In order, frontal, ethmoid, zygomatic, lacrimal, M is maxilla, P is palatine, and S is sphenoid in that orbit. Here in the nasal cavity you have the nasal bones on the crest joined together by hyaline cartilage. The nasal septum dividing the nasal cavity is made up of 2 bones, the vomer coming up from below, and the perpendicular plate of the ethmoid from above, cutting the nasal cavity into 2 separate portions. Around the cavity would be the maxilla. On the maxilla, the top jawbone, we're going to find the alveolar margin, which is where all the teeth connect. The teeth is a specific type of joint called a gomphosis. It is limited in its movement. It's a peg and a socket essentially, and this top margin here is the alveolar margin. The alveolar process is where an individual tooth fits into that socket. Down below this is the mandible, and on the mandible we have right here the cleft chin. This is called the mental symphysis. The mental symphysis of the mandible has on either side of it the mental foramina, these openings. And then if we look along this edge, this is the ramus of the mandible, a lot like we saw in the curvatures of the lower part of the os coxa. Curvature here is the angle, and that's called the mandibular ramus. Here we have a pointed process on the mandible. This pointed process is referred to as the coronoid process, just like the name we saw in the bottom part of the trochlear notch of the ulna. Coronoid process. This piece right here, the condyle that you see that's rounded, this is the mandibular condyle. It fits right into the temporal mandibular joint, and often with dislocation of this maternally inherited trait, this would click during chewing of materials, of food that's harder to chew. So that fits right up in underneath there, and the reason you can hear it so loud is this is the external auditory meatus, the opening to your eardrum. The zygomatic arch that sits right up above the coronoid process of the mandible is made up of 2 pieces, the zygomatic process of the temporal bone and the temporal process of the zygomatic bone, forming that arch. As I move this out, you can see on the mandible there's a couple of pieces here that are medial, and this foramen, this opening right here, is the main one that I want to mention. That's called the mandibular foramen. It's what allows for innervation of all the bottom teeth along the alveolar margin. You can see also here along this surface, where the mandible was just joining along the teeth, you see that the piece that we're looking at here is the actual maxilla, the top of the jaw. And the maxilla has an incisor foramen right there, and then it joins posteriorly with two L-shaped bones here and here called lacrimals, and they make an M along this, not lacrimals, called palatine bones. And these palatine bones join with the palatine process of the maxilla to form the roof of your mouth or hard palate. Stabilizing the back of the top of the jaw would be these two pterygoid processes right here and here of the bottom part of the sphenoid bone, and just posterior to those leading towards the foramen magnum and the occipital condyles, we see the foramen lacerum, which is a combination of three bones together, the sphenoid, the occipital, and the temporal petrous portion. On this side, we'll go over foramina later on. We'll do that in the next time. But basically, it's a good idea as you study this to study it using a broom bristle, and the broom bristle could be used by putting the broom bristle through each of these foramina like we will in the next video. And those foramina can be learned basically on both sides at once. There's only a very few of them that do not surface on the opposite side of the skull. For example, if I wanted to learn this foramen lacerum, I could put this broom bristle through and show that it leads directly through on either side of the plate that we find on the surface right here. See, it's there, it's medial. The occipital bone is back here, and the wings of the sphenoid are here, these lesser wings. This structure right here is extremely important. This is a saddle-like structure. It's called the sella turcica of the sphenoid. And this structure is our linkage between these openings. There's two optic canals that lead into the eye. That's your visual acuity and your visual sensation. And this impression right there, the sella turcica of the sphenoid, is where the pituitary gland sits and is protected. So instantly, with visual cues, you have the ability to release hormones from this master gland that's protected right there in that structure. You see a bear coming towards you, you're going to release adrenaline. That's where it comes from. Okay, now on either side of this, you see the foramen lacerum again, and the cranial fossa, anterior, middle, and posterior cranial fossa. And that's about it on the skull. Now, if we look at the skull individually with each bone in mind, we're going to see the sphenoid by itself, disarticulated, and the sphenoid this is an important one to look at because it's the keystone to all the cranial bones. So that's where it fits in, just like so. There is the structure I just mentioned. Right there, that's the sella turcica, where the pituitary gland sits, the optic canals through the lesser wing here and here into the orbit of the eye, and it sits just like that with the wings seen out here along the side underneath the arch of the cheek. So sphenoid is one that we're going to learn next time as well by itself. Ethmoid is another. Here's the ethmoid, and when we look at the ethmoid bone, it's situated like so. If you look into the cranial cavity, this is the ethmoid, the cristagalli right there, that thin line. It means rooster's cap, cristagalli, and on either side of it you have foramina, olfactory foramina, and the cribriform plates. Those are seen right there. This is how the ethmoid goes in. If I were to take the ethmoid out, this is what it looks like. The pink part at the top is the superior nasal concha, blood-filled sinuses in your nasal cavity that receive innervation from the first cranial nerve and process olfaction or smell. Right underneath that, you see these two brownish portions of that ethmoid bone. These are the middle nasal concha, and then the yellow in the middle is what we talked about at the beginning that helped divide the nasal cavity. It's the perpendicular plate of the ethmoid, and it joins with the vomer from below to divide that cavity. So you can see the ethmoid from cranial view here, and you can see it from a nasal view, and remember it's the medial wall just posterior to the lacrimal bone in the orbit of the eye that we talked about. All right, if we now look at the temporal. Temporal has four portions to it. Here's where it's coming from. This hardened portion right here, just behind the opening to the ear, is called the mastoid process. This is a large process because the muscle in the neck that joins to the clavicle and sternum that helps you flex your chin, bring your chin down, is going to be connected right there. That's the insertion point of that muscle. The opening that we see right here on the side is the external auditory meatus, or the opening to the eardrum. Just anterior was where we looked at the temporal mandibular joint and the mandibular condyle, the rounded structure that clicks because of your mother passing that trait to you. And then we see a pointed styloid process like we saw in the radius and ulna. The styloid is this pointed process down below. So in between the mastoid and styloid structures, you're going to have a stylomastoid foramen as well. That's one that doesn't surface on the other side of the skull. The temporal bone is the most dense and hardest. That's called the petrous portion of the temporal bone. It's going to be important because it protects the inner ear structures that process dynamic equilibrium and balance, linear acceleration and static equilibrium, and sound processing. All right here through the internal acoustic meatus in the petrous portion of the temporal. This thin line is called the squamous portion because of its squamous suture with the parietals above. This is the zygomatic process of the temporal that joins anteriorly with the temporal process of the zygomatic bone. And inferiorly, right here, a very important pathway, this opening that we see here is the carotid canal that leads the carotid artery up through the foramen lacerum and into the brain. The second pathway of blood into the brain, other than the vertebral artery, we'll see in a minute. So temporal's got a lot of good stuff on it as well to learn. This is the bottom of the hard palate and the roof of the mouth. So this is the left side of the jaw, goes right there. Right, so you can see the palatines, different color right there, that's palatine bones. There's the rest of the maxilla, the floor of the maxilla is the roof of your mouth, the hard palate. And then derived from the maxilla, the inferior nasal concha, the one we left out because the sphenoid had the superior and middle nasal concha on it. Okay, so here's the maxilla. And then medial on the maxilla, up in the corner of the orbit of the eye, the lacrimal bone, which is green right there. Okay, and here's the alveolar margin, where the teeth connect, and where one tooth connects is the alveolar process. Okay, this bone, this skull sits down, the occipital condyles sit down with the foramen magnum feeding the brainstem through it and into C1, atlas, and axis. Here's C1. This is the atlas. Notice the curvatures here. The more concave curvature on the top of the atlas is what goes superior, that process, with the occipital condyles. And then the atlanto-axial joint between C1 and C2 sit like so that you can still pivot your head and not break your neck. Okay, so this is C2, the axis, and this is C1, the atlas. No body on that structure because the brainstem is so wide and the condyles need to actually articulate, the head rotating. Now when we look at the C1 and C2, we'll look at, we good?
Yeah, I thought we were going to separate those out, right?
I figured I'd just keep going. Sorry, man.
No,
we're good. Stop.
No, just because we're rolling.
Okay, there's the need to differentiate between each of the types or regions of the vertebral column. The first 7 bones of the vertebral column are the cervical bones. As you can see, each of these structures, each of these bones have on them transverse processes. All of these regions have transverse processes, so I'm going to use this bone right here real quick to show you those basic pieces. This is the most posterior structure. This is the bump you feel on the back of your neck. This is actually the spinous process. Laterally out of this irregular bone, you're going to have transverse processes also. The body is the most anterior of the vertebral structures. Above, on the top, at least in most of the regions, you're going to have a superior articular process here and here, and below it an inferior articular facet that prevents any movement forward or backward and severing of the spinal cord along its path. When I put 2 of these bones together, so you're going to see a combination in spinal nerves coming out of the side, but when we look straight down through the area in the center of this bone, you see the vertebral foramen right in the middle that carries the spinal cord. If I put two bones together, one on top of the next, the transverse processes of these two make a foramen that's lateral in between the transverse processes, and the spinal nerves, 31 pair of spinal nerves, come out through these intervertebral foramina. So there's the vertebral foramen down the center, and the intervertebral foramina made by two bones coming together with fibrocartilage intervertebral discs in between. As you look at the different portions of the bone, you, in addition to having these processes and articular surfaces, will also have an area that connects the spinous process to the transverse process, and that is the lamina, and connecting the transverse process to the body of the vertebrae would be the pedicle or pedicel. Those are common structures throughout the entire vertebral column. Now we would need to distinguish one first cervical and second cervical from the rest of the cervical, the thoracic vertebrae, the 12 thoracic from cervical, and the lumbar, the weight-bearing region, from the others. So as we look at cervical, the primary characteristic that you're looking for to distinguish it from all others is that each of these bones will be the pathway for one of the two main blood supplies, the vertebral artery, that becomes the basilar artery, right here. It anastomoses one artery from one side, one from the other, into one artery or vessel called the basilar artery, which supplies the circle of Willis, or the blood supply, to the brain. The brain can't go without blood for any extended period of time, more than 3 minutes or so, or systems lose function. And therefore there's an alternative pathway, as we saw before in the temporal bone, that's inferior in the temporal bone. Carotid Canal, right here, through the petrous portion, will be the pathway of the carotid artery, internal carotid, that will go through the temporal and go into the brain through the Foramen Lacerum that we'll talk about later. So this opening, or these transverse foramina that you're seeing right here, here's the first cervical vertebrae. Every other cervical vertebrae has it as well. This opening right here is a transverse foramen for the vertebral artery into the brain. Every one of these bones, the cervical vertebrae, all have this opening laterally for that blood vessel, and so that's the distinguishing characteristic. If you note the transverse processes of the thoracic and the lumbar, neither of them have that opening. In addition, you have on most of the cervical vertebrae, this is a model that shows the spinal cord as it descends through the vertebral foramen. Many of all but three, actually, of the cervical vertebrae are going to have a bifurcated or a V-shaped spinous process because of the fact that this area is the anchoring point, the top anchoring point, superior most anchoring point of the ligamentum nuchae, the band of elastic connective tissue that joins together and prevents any over-rotation and severing of the spinal cord in the vertebral column. Just below these first 7 vertebrae, we're going to see the thoracic. This is one from the middle of the thoracic region. This bone and 10 others in the 12 are going to all share 12 articulations. Each bone has 12 different contact points with other bones, whether it be a rib or another vertebrae. We pointed out each of the structures here. What varies in this region is the point that you see right here, this articular surface. This is called the transverse facet, and that is for the tubercle of the rib. The rib is going to connect, the head of the rib will connect on the demifacets on either side of the body, one above and one superior here. And so one rib attaches to 2 bodies at once, and the tubercle on the rib will attach right here to the transverse facet. The thoracic vertebrae are associated with the rib cage, and therefore if we look at this in the correct orientation, this is the anterior-most structure. If it's anterior and the rib is going to come, this is a rib, it's coming around and connecting with it. The pointed part right here, this blade or thin part, is always inferior. The tubercle and head will go posterior, and the vertical cut for the costal cartilage is anterior. So therefore, this is a left rib. If it were to connect to this bone, as it would, It's going to come around, it's going to, the tubercle will attach to the transverse facet right here, and then the head will continue in like so, and connect itself to the top part of the demifacet from this body, and the one above it is going to have an inferior demifacet like you see below this, that will connect to this head of the rib as well. One head connecting to two bodies at once, and a tubercle in the transverse facet. So there's a few characteristics on this bone that I would use. I would use the circular vertebral foramen and the facet right here for the tubercle of the rib, as well as an elongated giraffe-like structure to the spinous process in this region. If I compare this thoracic structure, this thoracic vertebra, to a lumbar, notice the size difference in the body of the lumbar here versus here. So as we said before, the foramen, the vertebral foramen, is going to start large in C1 and decrease in size all the way down to the last lumbar, whereas the body will start small or not at all and get bigger as it moves down, because the lumbar region is the weight-bearing region. And notice it also looks sort of like a moose versus a giraffe. Okay, so you'll cut one of those out. There's the giraffe of the thoracic region, much larger body right here, and this is where we'll terminate the actual spinal cord. No more transverse facets, also large body, lumbar region, 5 lumbar, 12 thoracic.